come with will just be review for the exam on Tuesday. And then there will be no formal class until the final. I will hold a review session. I don't remember what day I have that scheduled for. One of those days in between the test and the final. So come in and just kind of get an idea of what areas to focus on for the final. Okay. Remember you have the lab exam over the head and neck on Thursday. So I advise coming in and taking it. I mean, I can't ever force you to take the test. It's up to you. But I advise coming in and taking it just in case you do well and you drop a lower score, or just as a help you to gauge how much you know the information and maybe what areas to focus on for the exam. Okay. All right. Unfortunately, our guest speaker that I wanted to bring in fell through. She ended up not being able to do that. So, bummer, it was fun, but we'll survive it. All right, let's start this final week of lectures off with a prayer. Gracious Father, you brought us through almost a whole semester, and we just pray for the extra kick of strength that we need to get through the rest of it. Help us as we study this week to be able to understand the material, to retain it well, and be prepared for the exams coming. Thanks so much for an awesome day and for just having a little bit of a break last week. Okay, so last time we talked about the muscles that are involved in mastication. What are those 4 muscles? One here is the temporalis, we got the masseter, and then there's 2 more. Lateral and medial pterygoid muscles. There we go. Okay, so remember the temporal fossa is where the temporalis muscle lives, and then the infratemporal fossa is where those pterygoid muscles are. And so when we're talking about vascular supply and innervation of these areas, a lot of what we're talking about is supply to those muscles. Okay, so we'll start off with the temporal fossa. So we have the external carotid artery coming up, and splitting off of that is the maxillary artery, and then it's small branches off of those that interconnect and go up to the temporal fossa. Okay. We also have some branches off of the superficial temporal artery, so these are ones we've seen before. Again, branches off of that to join this plexus here in the temporal fossa. Now, if we move into the infratemporal fossa, it's same story, second verse. It's the maxillary artery. He's the star of the show for this portion. So again, just small branches of the maxillary artery. It's as much as we really need to get into for this class. Okay. All right. Venous drainage for the temporal fossa. They don't show it very well, but most of the venous drainage from the temporal fossa is going to come in through the superficial temporal vein. Then we have this mess here in the infratemporal fossa, and this is the pterygoid venous plexus. Okay. And that drains into the internal and external jugular veins, both, and also sends some emissary veins into the cavernous sinus. Emissary veins. All right, make sense? Pretty simple. Any questions? Okay. All right, so then innervation. So again, we're talking about little branches coming off of a major nerve, and the major nerve is this one right here, V3, and V3 is the mandibular nerve. And it's a branch off of which main cranial nerve? Trigeminal. Trigeminal, because it has those 3 branches. Good. And it's supplying both sensory information and motor information. Large degree of it is sensory, but it does contain both. All right, and again, we don't need to know the little branches names, we just need to know the big one. All right, so here's another picture of that mandibular nerve, and we do need to talk about the lingual nerve. This is one of the main branches that comes off of it, and the reason we need to talk about it is it goes to area right here around the tongue and innervates the submandibular and sublingual salivary glands. Okay. So you can see it here again, traveling down from the maxillary nerve. And this image is kind of funny. It shows the parasympathetic fibers, but it doesn't show them running in the nerve tract, kind of wandering off on the corner somewhere. So let's take a look at it, dissect it out. This is a little bit better image. So for the sublingual and submandibular salivary glands, we have parasympathetic fibers coming from the facial nerve. Okay? So we follow the track. And then remember, we're talking about the middle ear, the chorda tympani, that travels up over the top of the tympanic membrane, right here. This is its rest of its journey. So it's going to travel down, and primarily, the parasympathetic nerves, fibers in that nerve are going to innervate these 2 salivary glands, sublingual and submandibular. So I've got here. And then the chorda tympani also, remember we talked about it carrying sensory information from the anterior 2/3 of the tongue. Okay. So then our other salivary gland, the parotid gland, gets its innervation via parasympathetic fibers again from the glossopharyngeal nerve. And it just briefly joins the mandibular nerve here before it takes off to the parotid. So this is all parasympathetic. Does that make sense? Okay. All right, so we have one more fossa we need to talk about in terms of the head, and it's the pterygopalatine fossa. And it's kind of a funny little teardrop shape. It's kind of tucked in up here in the bone, upside down teardrop shape right there. And you kind of see it blown up right here. And it's not really necessary to know the bones that are forming the walls, in my opinion, just to know kind of where it is, what its shape in general. Do know that it's kind of superior, or not superior, inferior and posterior to the nasal cavities. Here's the nasal. And it's superior to the oral cavities. Oral cavity, there's one of them. Anyway, so kind of the general idea of where it is. What really matters is what goes through it. Okay? And so it's a major pathway for the maxillary nerve. Okay, so V2, remember our maxillary nerve. It travels through fossa and sends a lot of branches out from it within that this word, pterygopalatine fossa. Okay, it's going to send branches to the soft palate, to the hard palate, to the facial structures, nasal cavities, sinuses, teeth, all kinds of places. Okay. Eventually we'll probably talk about some of those when we talk about the sinuses and in the oral cavity, but at this point, just know that they're going to be coming from the maxillary nerve. It is sensory information. Okay. All right, we also have some autonomic, so sympathetic and parasympathetic nerves coming in and passing through the pterygopalatine fossa. I'm going to say it differently every time, I think. So we have from the sympathetic trunk, coming up from the cervical ganglia there. They're going to have some post-ganglionic fibers come up, and they travel along the arteries. So in this case, traveling along some of those portions of the internal carotid artery, and also some of the branches off of it, to close to where it needs to go, and often will join in with some of the nerves here. And so, for example, the parasympathetic fibers going to the lacrimal gland. So here we've got parasympathetic fibers coming in. The lacrimal gland are going to travel through a portion of the pterygoid fossa and join in with the lacrimal nerve via this kind of little shunt here, unnamed shunt there, and then join in with lacrimal gland there. So that would be the parasympathetic nerves joining in. Okay. I know that's kind of a basic idea. You can see that here these autonomic fibers are joining in with those nerves there. It's a better picture there. And then spanning out and traveling with the sensory and or motor nerves to their target organ. Okay, so with the lacrimal gland, we have its parasympathetic innervation coming up from the maxillary nerve, the pterygopalatine fossa. And so what happens if that area is damaged when you lose parasympathetic innervation in the lacrimal gland? Yeah. Dry eye, so you're not going to be able to produce tears. Dry eye, surface of the eyeball dries out, you can actually cause permanent damage, eventually lead to blindness. Okay, any questions? Kind of idea of what's going on this slide? Okay, where'd your head then? All right, so we have some arteries and veins. This is going to be a little bit hand wavy because, again, we don't need to know the details of some of the little arteries and veins. But again, the maxillary arteries coming from the infratemporal fossa, and it's going to pass through the pterygopalatine fossa and send branches into it, through it to various structures. And so the maxillary artery is going to be supplying the hard palate, the soft palate, again, nasal cavities and sinuses, same regions as the maxillary nerve. All right. For the veins, then we've got our pterygoid plexus. And so basically what we have in the pterygopalatine fossa is just a lot of small veins coalescing and to drain into the pterygoid plexus. And these are going to be the veins draining the same region as the maxillary artery is going to be supplying to those same regions. That is all we need to know about that. Okay, any questions about those fossae? No? Okay. So then we're going to kind of skip the oral cavity for a while, the nasal cavities and sinuses, and jump to the neck, and then we'll finish up with the nasal and oral cavities. So remember, first lecture we talked about a couple of access points for structures in the neck, the anterior triangle, So kind of from midline of the neck to the anterior margin of the sternocleidomastoid muscle, and then going from the superior border of the neck along the inferior border of the mandible to the top of the sternum. Okay. And this is going to contain structures that are going between the head and the thorax. Then we also have the posterior triangle, and we have that between the posterior margin of the sternocleidomastoid muscle and the anterior margin of the trapezius, and then its lower border would be the upper margin of the clavicle. And it's going to contain structures that are going between the thorax or neck and the upper limb. So moving into that axillary region. Okay. And you know, for clinical release, these are areas where there's not big muscles overlying some of these deeper structures, so we have a little bit easier access into them than say going through a big muscle like the sternocleidomastoid. So here's just another image of it, showing the two muscles kind of from a lateral view. Don't need to belabor it any more than that. Just knowing that the sternocleidomastoid is the muscle that kind of divides the two main triangles. Okay. So then let's look at a cross section, and I want to just point out here. Here's our triangles. So this here would be which triangle? So this muscle right here is the sternocleidomastoid. This would be the trapezius. So this muscle, this triangle here, this gap between them would be the posterior triangle. And then here's midline, anterior midline. So the space right here would be our anterior triangle. Okay, see that? Okay. So then you can see how if we need to get into structures here, within one of the compartments of the neck, these triangles kind of allow for a little easier access. So then remember the compartments, we talked about that again at the beginning of the chapter. So we have the vertebral, which surrounds the vertebral column and all those back muscles associated with it. We have the vascular compartment, which surrounds the major blood vessels and also the vagus nerve. And then we have the visceral compartment, which I obliterated hands, clean things up a little bit. Visceral compartment, which surrounds the trachea, esophagus, and the thyroid gland. Okay. And then, so you need to know the fascia that bounds each of them. So this is listed here. Pretracheal bounds the visceral. The carotid sheath bounds the vascular. And the prevertebral bounds the vertebral compartment. And then there's the one last one, the investing fascia. And this surrounds the muscles. Muscles, superficial muscles of the neck. Anyways. Okay. So you need to know compartment, fascia, and then contents. And so the contents are actually listed out on the next slide for you, so you don't have to go guessing. Okay. So you see here trapezius and sternocleidomastoid labeled there. So again, being familiar with this three-dimensional structure is going to be important for understanding imaging. So MRI is typically three-dimensional. cross-sectional. So trying to switch from just looking at like a normal image to these cross-sectional diagrams is going to be helpful in translating your knowledge of anatomy onto imaging results. Okay, so then, remember like in the mediastinum, we had spaces between the different compartments. We have the same kind of thing going on in the neck. So we have these spaces, and the two I want to focus on are the retropharyngeal and pretracheal spaces. So our retropharyngeal space right here, kind of tucked in between the visceral and vertebral compartments. How many V's running around? Okay, and that's this one right here, on this cross-sectional diagram. And then we have the pretracheal space. And that is just in front of the visceral compartment, so it's kind of tucked in right here. Now, what's important about these spaces? Well, since they are spaces and filled with connective tissue, they can be locations for fluid accumulation. So sometimes, say if you have perforation of the esophagus, the fluid will collect in this retropharyngeal space. Also, locations through which infection can travel. So these are just empty spaces. They're not bounded by fascia, so they can travel through these spaces. Subdivisions of the anterior triangle. Just in case you run it into it at any point, but it's not going to be like super big important. So you have some of these muscles, these strap muscles on the neck, and some of these muscles right superior to the hyoid bone that separate out the anterior triangle into the submandible, mandibular triangle, submental triangle, the muscular triangle, and the carotid triangle. Okay? So be aware of them. The only one we're going to really talk about further is the carotid triangle. We're going to briefly mention the location of the carotid system within it. But other than that, just be aware of them and just kind of get an idea of which muscles form the divisions between them. So we've got our normal hyoid, digastric muscles. Beyond that, that's not too super important, but just so it's kind of passed through your brain a couple of times, just in case you remember it at some point. Okay. All right. So then, kind of back to the anterior triangle in general, just point out some of the superficial veins that we should know. So these should be mostly very familiar. So we have the external jugular vein, though it's not in the anterior triangle proper, it's kind of close to it, so we'll mention it. And I just want to mention it also because this figure shows very nicely how the superficial temporal vein, the facial vein, the maxillary vein all feed into the external jugular vein. You can see them all coalescing. Okay. The other one I want you to know are the anterior jugular veins. So these just run just on either side of midline, and they can become somewhat variable, especially in this region. And the reason I point them out is because we have the jugular venous arch here, which joins these two anterior jugular veins together and kind of sits right in this region here. You got to be aware of. The variations seem to be what they empty into. So some of them empty into the internal jugular, sometimes they empty into the external jugular, sometimes they go directly into the subclavian. they do what they want. That's how some superficial veins roll. So, but just be aware that they're there somewhere. Okay? All right, then major arteries in the neck. So, in general, it's the arteries are the carotid system. And that, of course, is formed by the common carotid artery, which bifurcates into the internal and external carotid arteries. Remember, the internal carotid artery goes to the brain. So right into the cranial vault and supplies the brain. The external carotid artery sends branches out that supplies the majority of the neck structures, so including like the thyroid gland, etc. We'll get into the details of that later. And then just want to point out the carotid sinus. So that's that point right here at the bifurcation of the internal and external carotid arteries. And what is there? What are the important things that are there? Baroreceptors.
Chemoreceptors.
Mm-hmm. So those detecting blood pressure and blood chemistry in the carotid system. Okay. Good. All right, so here's just that one brief mention of the carotid triangle here. And just want to show that we have the internal and external carotid arteries coming through that superior portion of the carotid triangle. And that gap between the muscles there is what allows us to take the carotid pulse. So that's the location of the carotid pulse there. Okay, so we're done with the subdivisions of the anterior triangle. All right, so a couple of notes on the roots of these major vessels of the neck. So a couple of things I want to point out. First of all is that the veins are anterior or superficial to the arteries. Okay? And then also, posterior to those vessels, we have the apex of the lungs coming up. Okay? So we have to remember, in the root of the neck, we have the apex of the lung pushing up into that region. And that's just behind those vessels. Okay, why is this important? Well, we have central venous catheters, and these are placed typically when either the patient needs a lot higher volume than you can give with a peripheral IV, or if they are trying to deliver some substance that is known to cause inflammation of the veins or phlebitis. And so they want to thread a catheter into either the right atrium or the junction of the superior vena cava with the right atrium, and that allows them to take fluids either in large quantity with a larger bore catheter, or they can dump those drugs right into a larger volume of blood and allow them to be more dilute more quickly than they would with a peripheral IV. There's two main insertion points. They will do them through the subclavian vein or through the internal jugular vein. By far, appears, from at least what I've read, the internal jugular is the preferred location, and that is because that subclavian artery is tucked in right there behind the subclavian vein. Yeah?
It's going to depend on how long they're going to keep that catheter.
Oh, really?
Because if they're going to do a PICC line or something like that, it's going to be long-term, you're going to go subclavian.
Okay.
Because there's less chance of it getting kinked off in the neck.
Oh, that's true.
So you have an increased risk of pneumothorax going subclavian, but it's
Right.
more stable long-term.
Okay, so it's worth the risk then. That's really interesting. Okay. Yeah, so then like she said, not only can we puncture the subclavian artery, we can also potentially puncture that apex of the lung and cause pneumothorax. So, good. so then here we have the internal jugular insertion there. Okay, so then here is a radiogram showing the inserted catheter. This is a jugular insertion, so see here, kind of going from the tip of the catheter, so the heart kind of tucked in right here. Oops. Making the heart a little bit enlarged, so it's not good. Patient has enough problems. Okay, so there's kind of an outline of the heart, kind of the junction of the right atrium and the SVC right there. You see the catheter threaded up through the SVC, and then up into the internal jugular. And then exits the vein, and then usually somewhere in this region it'll exit the body, and then you see the rest of it just kind of laying on top of the patient. So when they're placing these things, do they use ultrasound to kind of help guide the placement? That's what I thought.
Depending on if it's like an urgent situation or if it's planned. Most of the time if it's in the ER or something like that, you're gonna see the jugular placement. It's a lot easier to do without ultrasound guidance. But if you're gonna be talking like an antibiotic infusion over, several weeks or a month or something like that, then they'll do, subclavian, especially if they need like large bore or something, some meds that's possibly necrotic to the tissues, because if that infiltrates, then you could lose a limb or something like that.
That would be terrible.
So when you're given like hardcore pressors and things like that, you do not want to run it peripherally. You only run it centrally.
Yeah, okay. Cool, and so then, I was also reading that, when they're placing the tip, they can also, if they push it too far, they can actually cause heart arrhythmias with the tip of the catheter.
If they float it too far through the heart, yeah.
So then, like, just the touch of it?
Yeah, you can hit the SA node or something like that.
Oh.
With the tip of it.
Okay, so then they pull it back and then make sure
And
that
you'll see
they're.
that more like if they're floating like a swan line or something, like if you're wanting to make sure like right atrial pressures or pulmonary pressures. You have to be careful when they're floating those.
Okay, very cool. It's amazing. I know my mom does this on babies. She's a NICU nurse, and I just am like, oh my gosh, how do you do that? That would be so scary, because she's one of the best in the hospital. I'm so proud of her. Okay, cool. Very interesting. All right. So then let's move on to the muscles in this region. So the suprahyoid muscles, or above the hyoid bone. So they're going to be important for elevating the hyoid. Some of them are used to depress the jaw or the mandible. Be correct. And so these are general, like lumping them all together. Not all of them will work in this. Each one of them has their particular job, but I'm not going to make you guys memorize which one does what. Just kind of in general is what they do. They help anchor the tongue. And form the inferior floor of the mouth, of the oral cavity. Okay. And so as far as you need to know, like we said at the beginning, you need to know the ones that you're supposed to know for labs. So myelohyoid, hyoid, stylohyoid, digastric, both bellies. Thought there was another one. Yeah, genial hyoid. Okay, so know those, where they are, and then the overall function of this group of muscles. Okay, so then we move to the infrahyoid muscles. So those are all muscles, the strap muscles. This is what we also call the strap muscles. And so they are often involved in depressing the hyoid. Or elevating the larynx. And this elevation of the larynx occurs when the hyoid bone is fixed in place by tension in the suprahyoid muscles, so then it can pull them up. And these, of course, will be all important in swallowing. You know, moving the hyoid, which can move the opening of the larynx slightly forward and upward to allow for efficient swallowing, not inhale in your face. Excuse me. Did I miss anything on that? That's good enough. Okay. All right, and again, know the same ones that you have on your lab list. So, have them here: sternothyroid, thyrohyoid, homohyoid, and sternohyoid. All right. So then, innervation of the infrahyoid muscles. Remember at the beginning of the chapter we talked about the ansa cervicalis, that loop of nerves coming as a loop out of the cervical plexus. Okay, these are the muscles, the strap muscles that they innervate. You can see them coming out here to innervate. Strap muscles. Okay. You don't need to know which nerve, spinal nerves they branch from, just know that they come from the cervical plexus in general. Okay. Right, so then we're just gonna march through the cranial nerves of the neck. So these are cranial nerves 9 through 12. And we'll just kind of note some position and a couple of smaller branches that are important. So we've got number 9, the glossopharyngeal nerve. Comes down and then passes into the oral cavity area, suboral cavity region, and since branches to the tongue and to the pharynx. So we've got main branches to the tongue, then we've got small branches to the pharynx here. And then we have the one I want you to really know is the carotid sinus branch. So this is going to be taking that sensory information from those chemoreceptors and baroreceptors up to the brainstem regions that are involved in regulating blood pressure and ventilation and other ways of regulating blood chemistry. Okay. All right, next one. One we're all familiar with, the vagus nerve. So it runs inside the carotid sheath, like we talked about. All the way down through into the thorax and beyond. We studied that already. And again, it sends a branch to those carotid sinuses. It's called the carotid body arch branch. As well as some areas to the superior larynx, so the superior laryngeal nerve. And then also we have, remember the other nerves to the larynx coming up from the vagus nerve. Which one is those? Come down, branch up, and come back up. Recurrent laryngeal nerve. There we go. So that's going to come back up here. All right. Next is the accessory nerve. It's a nice simple one. The motor travels through this portion of the anterior triangle to the posterior triangle and the underside of the trapezius muscle and innervates the trapezius muscle. It also innervates something else I'm blanking on. Is it the levator scapulae? I can't remember.
The sternocleidomastoid.
But the sternocleidomastoid, I can't remember. Anyways, one other one in there. But yeah, look at there. Got a branch. Okay, cool. So that's the accessory nerve, and this is the motor. All right, and then finally, where do we have it? It's hypoglossal nerve. Here it is. It's going to travel through the anterior triangle area of the neck without any real branches. So these other branches are of the the glossopharyngeal nerve. And this travels, this is again, it's motor, and it travels to the tongue. So this is what allows for tongue movement. And you can see it here kind of oozing over the top of the external carotid artery there. Okay. Clear? Any questions, comments? All right, 3 more lectures to go. I know, anything.